Welcome to Fertility Village. This is your weekly live talk show where community and support come together. With rotating hosts, expert guests, and meaningful conversations, we're here to guide you through the highs and the lows of infertility. Whether you're searching for answers, seeking advice, or just looking for a special place to belong, Fertility Village is your space to connect, learn, and grow. Because it really does take a village, and we are here for you every step of the way. Thanks for joining.
Hello, everyone, and welcome to Fertility Village Live. I am Sarah, and I'm here with...
I'm Caley, and today we are talking to Dr. Garcia and Dr. Wais from Markham Fertility and the MyFertilityPodcast. Thank you so much for being here. We appreciate it. We're so excited to talk to you about Fertility 101 today. But first, we were hoping that you could give us a little background on yourselves.
Do you want to start or do I start?
Go for it.
Okay, I'll start because I arrived late at the thing, so I'm going to start. That's my punishment. I'm Dr. Garcia. I'm the medical director at Markham Fertility Center. I started my fertility practice back in 2011. So it's been, what is the math there? It's been over 10 years that I've been doing this. I also have the pleasure of co-hosting MyFertilityPodcast with the amazing Dr. Wais. We've been doing that it's going to be a year in the middle of March. So we've been putting out one episode every week about different fertility topics. We interview different guests. We interview patient stories. It's been a lot of fun to do, and we've gotten a lot of wonderful feedback about it.
It's a wonderful podcast, one of my faves.
Thank you.
And I'm Dr. Marta Wais, and I'm one of the physicians at Markham Fertility Center, along with Dr. Garcia and the rest of our incredible team. I am the director of quality. So I am a podcast co-host on my fertility podcast, but I also have a big interest in quality improvement and quality assurance. And that's another one of my big roles at the clinic, apart from the podcast. And I'm just excited to be here and to talk about all things fertility, and excited to be here with one of my besties.
Amazing. Thank you. So we're going to dive right in because we only have an hour and we wrote way too many questions. So the first one is probably one you get all the time. But for those maybe new to fertility, what are the most common reasons you see for infertility and the need for fertility treatment?
Yeah, so a lot of people think infertility is a woman's thing, but it's not. It's actually, there's male factors and there's female factors. So a big part of it, in terms of female-related factors, could be ovarian dysfunction, like, for example, polycystic ovarian syndrome. To a lesser degree, things like premature ovarian failure, which is a condition where women go into menopause early. There is also a big component of infertility that could be related to endometriosis. Age-related infertility is really big, and it's something that is hard for people to understand because they always hear their friends getting pregnant when they're older, and then when it comes to them, it's more difficult. But it's definitely something that we talk about quite a bit. And then when it comes to male factor like sperm, it's about 50% of the causes of infertility come from sperm as well.
Is it that high? That's crazy.
Now, there's also a percentage that is unexplained infertility. That's about 30%. So about a third of cases is unexplained infertility, which I know nobody likes to hear that. I'm looking at you, Caley.
Yeah, full disclosure, guys. Dr. Garcia was my fertility doctor, and I have unexplained infertility.
It's a tough one, and we don't like saying it because it's really discouraging in a way, and it makes patients feel like, well, if you don't know what's wrong with me, how are you supposed to help me? Which is a fair sentiment for sure. But certainly, we have a whole podcast episode on it, and the take-home message is that even when you have unexplained infertility, there's lots of fertility treatment options that can help.
And okay, so we want to talk first about what are the basic tests you run for all your new patients before deciding on a treatment plan. And people like to know, how painful are they? How can they prepare?
Yeah, that's a very good question. So, obviously depends on the specific situation in terms of why you're coming to a fertility clinic. So, if you are somebody with ovaries and you're coming with somebody who has sperm, whether you're coming on your own as somebody with eggs and who has ovaries, or, there are some nuances out, but let's say in a situation where, you're somebody with ovaries with eggs, you have a partner who has sperm, maybe the two of you have been trying for some number of time and now you're coming to a fertility clinic. So the common investigations, and it's pretty standard, I would say, across the board amongst fertility clinics, like maybe some small nuances, but generally we're going to have both partners do blood work, and I'll get into that a bit more. We're going to have the partner with ovaries do some ultrasounds, and we're going to have the partner who has sperm to do a semen analysis. So the blood work for both partners is going to include infectious disease screening. So looking at things like, hepatitis B, C, HIV, syphilis, that kind of thing. Again, the reason is that our goal is to help you get pregnant, but to also have a healthy pregnancy and a healthy baby, right? And we know that these things can be managed or treated in certain ways and can affect the health of babies. That's why we're looking. We're also going to be checking some hormones in the partner who has ovaries, let's say checking the thyroid. We might do blood counts just to make sure, in terms of general health is being okay. On the ultrasounds, so there's 2 ultrasounds that we're going to do. The first one is just sort of a general pelvic scan, typically done within the first few days of the menstrual cycle day 3 to 5. Again, cycle day 1 being first day of the period. And so with that scan, we're looking for things like fibroids, endometriosis, adenomyosis, weird cysts on the ovaries, et cetera, to get kind of a big, just sort of good look at the pelvis. We're also going to take a good look at the ovaries specifically to do something called an antral follicle count. So this is one of the tests that we do to start assessing egg reserve and to get an idea of, how many eggs may be remaining in the ovary. Apart from that, another blood test that we may do in patients with ovaries is an AMH, or an anti-Müllerian hormone level. Again, another way to assess that egg reserve number. So the ultrasound that you alluded to that may be a little bit more uncomfortable is the sono, or otherwise known as a sonohistogram or an SHG.
We don't like it.
I don't think anybody likes it, to be honest, but I tell people, listen, it's not the most fun thing in the world. It's generally crampy, feels like menstrual cramps, involves putting a speculum in the vagina, which for some people can be very uncomfortable. And we put a little catheter or a tube through the cervix into the uterus to assess the inside of the cavity. And I tell people, at baseline, the front wall, back wall of the uterus are smushed together. So when you put fluid in, we can actually really nicely delineate the inside of the cavity in a way that we can't with a regular scan. From there, we can then follow to see if, the contrast is flowing through the tubes to assess if the fallopian tubes are open or not. So first of all, I tell people, listen, the people who go on the internet and say that the sono is really bad are people who had really bad experiences. Because if you're somebody who had a sono and it was like, meh, wasn't great, but it was like, okay, like you're probably not going to go on the internet and like write about it. Right. So through those extreme experiences where people have that motivation to go and, pass on these stories, the vast majority of patients will feel cramping, like bad menstrual cramps, but it lasts 5 to 7 minutes, generally speaking. So the vast majority of patients do very well with the sono. Again, nobody loves it. It's not going to be like the time of your life, but it gives us a lot of good information. So it is a really important part of the investigations.
And Sorry, go ahead. Go ahead. Sorry.
So I was just going to say, so we often advise people to take like Advil beforehand as well, to try and kind of mitigate some of that discomfort.
I was just going to add that a lot of times patients come the first time and they have a painful sono because they've never had children, and then they're able to achieve a pregnancy and come back the second time really scared that it's going to be terrible. But after the uterus has stretched to have a baby, the sono is much less painful. So for anybody who is kind of in that situation, there is a little spoiler for you that the second time coming after having had a baby is not so bad. I'm looking at you again, Caley.
You know, when people have asked me about it, I say it's sort of like going for a pap smear. It's so quick. It's a little painful, but it's so quick. You can get through it. Yeah. Can you walk us through the steps of IVF high level for someone who's really, really new to the process? What does that look like, and how is that compared to mini IVF?
Yeah. So the steps of IVF and mini IVF are very similar because they're both required meeting with the physician, making a cycle plan. Then the process usually starts with the day 2 of your menstrual cycle. We can get into whether you're doing a luteal steam or not, but let's just stick to the basic. So it starts on day 2 of your menstrual cycle for both, for a standard IVF and mini IVF. You're taking injections every day for about 10 to 12 days. And then there's cycle monitoring that is happening. So that could be initially like on day 2, then again on day 5, then again on day 7, 9, and then by day 10, 11, your follicles should be ready. Once the follicles are ready, we give you a medication called the trigger, and then 36 hours after that, you come for the retrieval. So that's the same for both. The only difference between a standard IVF and mini IVF is that in mini IVF, you're using less medications. So if in a standard IVF, you're getting like 450 units of total in medication, in a mini IVF, you might be getting 150 units of medication, maybe 200 units of medication. A mini IVF, I mean, Dr. Wais and I love our mini IVF cycles, and we normally use them in patients that have, it can be used on anybody, but the most common situation is in patients that have low ovarian reserve, and we know that they have a low AMH, a low follicle count. We know that giving tons of meds is only going to lead to 2 follicles. So might as well give a little bit of meds and just get those 1 or 2 follicles as well. Sometimes patients do better in that situation because the follicle doesn't get oversaturated with too much medication, knowing that there really isn't more eggs to make anyways. So you're not going from making 10 eggs to making 2 eggs by doing mini IVF. You're going from making 2 eggs to making 2 eggs by doing mini IVF because that's the most that you can make. So the processes are the same. And then after the retrieval is done, like I said, after the trigger is done, you come for the retrieval. At Markham Fertility Center, we have anesthesia. So you get medication and you're completely asleep. The wonderful medication, a wonderful medication called propofol, which really is magic. It is magic.
My favorite nap ever.
It's like the best nap ever. I know when I was going through my journey, I was like, this is the part I like. And then the eggs get retrieved. Usually sperm is produced that day. Maybe it was frozen if you're using donor sperm. Maybe it was frozen for other reasons. But most of the time, the male partner produces sperm on that day. And then the eggs and the sperm come together. That could be through IVF, where the sperm fertilizes on their own, or through ICSI, where one sperm gets directly injected inside the egg. And then you want those eggs to fertilize. Unfortunately, not all of them are going to fertilize, and we can talk about that after. And then the eggs that do fertilize need to grow in culture for about 3 to 5 days, depending on what the plan is. And then at that point, you could transfer an embryo back into the uterus. If the plan was for a fresh embryo transfer, you can freeze an embryo for future use, or you can freeze and do a biopsy, something called pre-implantation genetic testing for future use. So that's IVF in a nutshell.
That was a beautiful summary.
Perfect. And you did touch on when people were coming back, but can you give a number to how often patients would need to come to the clinic for an IVF cycle versus a transfer cycle?
Yes, that's a great question. Sorry, do you want to go ahead, Marta? Oh
no, go for it.
Yeah. So in an IVF cycle, usually for the monitoring would be like day 2, day 5, day 7, day 9. So about 4 times. And then the day of the retrieval. And then if you're doing a transfer, the day of the transfer. If you're not doing the transfer, there would be about 3 to 4 visits on the day of the retrieval. And in those visits, it isn't always going to be like, sometimes it's just bloods. And then it's going to be bloods and ultrasounds, and the ultrasounds could take not a long time if there's not a lot of follicles, but as the follicles grow and you have more follicles, can take a little bit longer. For the transfer cycle, it depends on the protocol for transfer. So if it's a medicated cycle, you only need to come once to check the lining because there's no hormones. We're not tracking any hormones. If it is a natural cycle, then we're tracking hormones and looking at the exact time that you're ovulating.
Dr. Garcia knows that was me. I came in a lot.
Yeah. So then, you're coming in a lot, especially if your cycles are long and you're ovulating on day 17. We normally start monitoring on day 10. And then it's like literally like watching water boil. And I feel so badly because I'm like, she's not there yet, but if I give her a day off, that's the day she's gonna ovulate and I'm gonna miss it. So you see like the estrogen is like 192 and then it's like 194 and you're so afraid to like give time when you know that it's really going, and at any point it can really, and we really want to get the exact time that you're ovulating. So it's really important to do all that monitoring.
Yeah.
And I'm going to cut it a little quickly too. Can you talk a little bit about a fresh transfer versus frozen transfer?
Mm-hmm.
Yeah, so
I want to take over.
So fresh transfer versus frozen transfer refers to the state of the embryo. So whether the embryo, meaning the fertilized egg, whether it is ever been frozen or whether it's fresh, meaning it's never been frozen, essentially. So in an IVF cycle, you can consider doing a fresh transfer, typically most commonly done 5 days post-retrieval. So when it's a day 5 embryo. And so that would be a fresh transfer. A frozen transfer means basically that, the embryos have been in the lab and they have then been frozen, and then we're thawing them for a transfer. There are lots of nuances to different types of frozen embryo transfer cycles that Dr. Garcia kind of alluded to, with like the medicated versus natural. Fresh transfers are all pretty common, or I shouldn't say common, but they're all kind of standard in the sense that there's not really much change in protocol because you did your stimulation. That was the protocol that prepped the lining, so to speak. So that one's a little bit less. Now, it's important to note that not everyone is eligible for a fresh transfer, right? So your physician may not even kind of really bring it up because they know that you are not going to be doing a fresh transfer. So in a situation where somebody's saying, you know what, I for sure want to do genetic testing of my embryos, that's important to me, you can't do a fresh transfer because the genetic testing takes time. So you have to get those results back. The other one is a situation where somebody may have a very high egg reserve and you're expecting a lot of eggs. Again, a lot, that can vary, what that definition is. But if you're expecting a lot of eggs, again, you may not want to do a fresh transfer. You may prefer frozen transfer, because any fresh transfer in somebody who made a lot of eggs, 15, 20 plus eggs, the risk of overstimulation is very high. And OHSS, again, that's a whole other topic of itself. But basically, you feel really, really bad to the point where you can end up really sick, and to the point where you can end up even in hospital, which is something that we obviously do not want.
Mm-hmm.
So say someone goes through all of the retrieval process and their transfer, and sometimes we know it doesn't work. Mm-hmm. Can you guys talk about what is that WTF appointment? What does it look like? I know it's a hard one to talk about. It's no fun.
Yeah, it's definitely not a fun one, but it's also, it's an important one. The first thing is, I always start by acknowledging that it's us. It's even if whether you're 43 and we were expecting it, or whether you're 23 and we were not expecting it, it's always upsetting no matter what. So we just start with that. And I usually ask patients, how are you doing? How are you coping? Who are you talking to? And all of those things. Then, once we get into the medical aspect, we go from the beginning. Okay, so this was your story. This is your age. This is all the factors we had to start with. We had endometriosis. We had ovarian reserve issues. We had an endometrioma. We had difficult access with the ovaries. We had BMI issues, diabetes, whatever it is that we had, like we talk about that. And then this is the reason why we chose the protocol that we chose. And I always say that it's not like you could do a blood test on somebody and be like, this is the perfect protocol for you. We go by experience. It's a bit of a guess, to be honest. We kind of look at many different factors and choose a protocol that we think is going to help in that situation. So we talk about that, and then I usually look at the pieces. So the stimulation piece, the egg quality piece, like what was it like when we look at your eggs, the fertilization piece, like what happened when the egg and the sperm came together, and then the blastocyst development piece, and then if there was PGT, that, and then the implantation part. Like, for example, I had someone today that she didn't have a good outcome, but she had really low ovarian reserve, and she ended up making 8 eggs. So yes, she didn't have a baby and she didn't have a blastocyst, but we're like, this protocol was amazing because we got you those eggs with what I thought wasn't going to happen with all of these other pieces, right? So it's important to understand, okay, I get these drugs into my ovaries and this is how many eggs we get. Then we have to look, okay, how old were the eggs? What was the quality of the eggs? What was the sperm like? And then you go through all of that. So sometimes when you break it up, you can say, okay, I got the right medications from my protocol. We got really good fertilization. You know, we made 1 blastocyst and it was abnormal. We know that based on age, like if you're 35 or over, if you're 35, it's 50-50, but if you get to be 38 or 40, we're talking like 70% abnormal, 80% abnormal if you're 40. So if you have low ovarian reserve, but you got like 8 eggs and 7 of them fertilized and 3 of them made it to blastocysts, and that all 3 of them were abnormal, or maybe you had 1 mistake or 2 abnormal one, but it was actually a really good protocol. We just need to do that. We need to work on the egg quality and know that, hey, you can make eggs, you can fertilize, and you can make blastocysts. Now we just need to make sure that they're going to be chromosomally normal versus somebody that didn't get any eggs at all. You know, maybe she ovulated early, maybe the ovaries were not accessible. Then that tells me, okay, let's go back and find a different protocol. Maybe we need to do dual stim. Maybe we need to add growth hormone. Maybe we need to change the medications completely. Maybe we need to do androgen priming first, or letrozole, or a million other things. So we break it up into all the pieces. We find the pieces that worked well, and then the pieces that didn't work, then those are the ones that we tackle for next time.
Mm-hmm. I think there's such a perception out there that it's like you go in, you do it once, boom, you're done, fertility over, right?
Mm-hmm.
Yeah.
No, it's definitely, yeah.
I know.
It was that simple, yeah.
Yeah, no, it's definitely not like that. I mean, I did it 5 times. It's not like you always learn something from every time that you do it. Like I say, you break it down and there is a piece, you throw away that piece that didn't work and you keep the pieces that work, and then eventually you get to the right. And then there is a bit of luck. I mean, some patients, you can do a cycle when you're like, I really don't know why, you know, you should have made 15 eggs and you made 12 and or at 10 and 3 fertilized. I really can't explain it because look at all the pieces. Yeah. And then we just say, let's do it again with different protocols, just because I don't want to do the same thing again, but it doesn't mean that I have something magical. I just think you can do better. You've got the pieces in you and you can do better. And then like many times they blow it out of the water the next time. Like I've seen patients go from making 1 embryo to making 7 in the next cycle.
And that's what's nice from an unexplained perspective, right?
Exactly.
Get a little answer maybe each time, right? Something else to look into, and it's kind of settling too as well when you get that little piece of the puzzle answered, right?
Yeah, and I always say to patients when we say, you know, your egg quality wasn't good, you know, it's the 8 eggs that we got today that weren't good. Like your next group, your next cohort of eggs could be very different. When we say, you know, the sperm really didn't fertilize, well, you know, that's the sperm that was produced in that day. You can just have better outcomes next time. So certainly, it's a difficult appointment, but I hope, like I always, you know, we've been there. Like it's always about finding what worked and find what didn't, and how we're gonna do what we're doing next time.
Yeah. And speaking of protocols, one of the reasons I came to Markham Fertility is because you're very unique in that you do immune protocols. Can you guys talk a little bit about what that looks like?
Yeah, absolutely. So, I mean, you know, for somebody who, let's say, has done IVF and maybe they have made lots of euploid embryos, and maybe just those euploid embryos, the genetically normal embryos, they're supposed to quote unquote stick and they're just not sticking, right? Or they're sticking, but somebody's having recurrent miscarriages. So this is the kind of person that we're thinking about when we might be thinking about immune. But, really, I think immune is part of a bigger puzzle. And that is kind of this recurrent implantation failure and recurrent pregnancy loss. So, recurrent implantation failure, I mean, even the textbooks, even the guidelines cannot agree on a definition, right? So it's like
Really?
2, maybe 3 failed transfers of maybe good quality, which can mean a whole lot of things, embryos, maybe euploid embryos, maybe in a row, maybe not in a row, right? So the fertility scientific community cannot even agree on the definition. So let's start there, right? RIF, yeah. Recurrent pregnancy loss, kind of the same thing. Again, we can't agree on definitions. So maybe 2, maybe 3 miscarriages, maybe consecutive, maybe not. And so, that's part of it. So when we're seeing patients who, let's say, have recurrent implantation failure or recurrent pregnancy loss, immune testing may be one piece of this big puzzle that we're looking at. And so the way that I always start with patients, I say, listen, the guidelines, the textbooks, the literature will suggest that, the next step should be to put in another embryo. That, the textbooks, the guidelines, the literature, whatever, do not recommend doing all this testing and all this stuff, right? However, intuitively, I mean, it's really hard to do the same thing over again and expect that things are going to be better, right? It's hard for me. It's hard for the patients, right? I mean, I think we always inherently feel like we want to change things up, do something different, offer something different. And so this is where, there is no great guidance about what to do and what the next step should be. And so that's where I will have a discussion with patients and say, listen, I always start off by telling them that this is not in the textbooks. I'm super open and honest about it. And I'll say, listen, so let's think about these things. So there's all these theories out there of why embryos may not stick or may not stay stuck. Could be the microbiome of the uterus. The uterus is not sterile. There's bacteria there. Some people feel maybe the bacteria there is not good, quote unquote, and that's the problem. Some people will theorize that it's this chronic inflammation of the lining that's the problem, this chronic endometritis. Some people theorize that there's this sort of occult inflammation that could be happening, right? So that's this occult endometriosis. Occult meaning that you may not be experiencing the symptoms of endometriosis, the classic symptoms, but that it's there and that it is causing problems in the pelvis. Some people will theorize that it could be, the protocol itself, the type of progesterone, the timing of progesterone, right? How long is that exposure of progesterone going to be before you're putting the embryo in? And then there's immune system. So, I mean, I think I would venture to say that every fertility specialist will agree that the immune system is really important when it comes to embryo sticking. And that if there's a problem with the immune system, that's going to be a problem for fertility. I will venture to say that every fertility doctor will agree on that one.
Makes a lot of sense.
Yeah. Where confusion, controversy lies is how do we actually test for this and how do we actually treat it? But this controversy lies in all of these things, right? So there's lots of tests out there. ERA, Emma, Alice, Receptiva, Fertilisys, Matrix, the list goes on and on and on, right? But none of these tests have really been validated, meaning that there's no studies to say, okay, you have RIF, we're going to do the test. If we find a thing and then we fix the thing, you're going to do so much better. Right? The literature is just not there. So that's where, if I'm seeing a patient, I tell them this whole long story. And then I say, listen, we are now stepping outside the box. Okay. we were in the box. Now we're going to step outside the box. And so that's where we're going to talk about all these different tests and decide how we feel about each of them individually, knowing that, there's not a ton of evidence to support any of them. And that's where immune is one piece of that puzzle, right? Certainly I think everybody can agree the immune system in some people is off. And so, at Markham Fertility Center, we've been doing immune modulating treatments, had this immune program for over 20 years. And it's something that we've done a lot of. And Dr. Garcia learned from Dr. Vero. I learned from Dr. Vero and Dr. Garcia. We've taught Dr. Chan and so on and so on and so forth. And, we all feel really good about it, because if we didn't, we wouldn't keep doing it. Right. So I think that we all have the wild stories about that patient who had multiple failures, and then we did immune, and then they did so much better. Right. And I think we hold those stories very close to our hearts, and they mean a lot to us. And so, we really do want to bring the studies and the literature and to do the research with immune, but it's really hard. And there's many roadblocks from, research ethics, board approval, and making protocols, and all these kind of extenuating factors that make things a bit more challenging. And so, one of Dr. Chan, so one of our colleagues, she's big on research. Dr. Garcia and I are not. It's not our thing. We podcast. We leave it to Dr. Chan.
We like reading studies. We just don't like doing the studies.
Yeah, fair. Exactly. That is absolutely correct. And so this is something that, an area of interest for her, but it takes time. And right now, all of the studies around immune, it's a dog's breakfast. So many studies are doing different things with different drugs on different people that it's you cannot make heads or tails of it. It's like comparing apples to oranges, right? So, I think that if somebody thinks they have an immune issue, or if somebody has recurrent implantation failure or has recurrent pregnancy loss, I think it merits a discussion, right? With one of us, basically, right? And as I said, I'm not trying to sell anything. I
was already sold.
But it's I think that patients get to a point where they're you know what? I've done all the things. I'm ready to try something different. I'm ready to try something out of the box. I know that there's no guarantee, but I feel like this is the next step in my journey, and that's the step that we take together.
Yeah. We have a couple questions about immune coming in from people watching. One of them is, do intralipids help with immune?
Yeah. So when I would say yes. I mean, we use intralipids. We can use it in people that do immune testing and have elevated cytokines, or we can use it empirically. Empirically means, and when we talk about immune, the first thing, like Dr. Wais, is talk to the patient and see their story. A lot of times they come to us saying, I'm here because I need immune. And then when you talk to them, you realize they don't need immune. They need really good IVF. They need really good protocol. They need good support. They need a lot of other things that are not necessarily the whole immune program. So part of what we do is figure that out. And sometimes we break it down. I said to patients, there is this testing that you can do that costs money. And like Dr. Wais said, there is all the evidence or lack of evidence, so to speak, or you can do what is called empiric treatment. So empiric treatment means you've done these transfers, it hasn't worked, we don't know why it is. We can give you this treatment that we're not sure is the actual answer to your problems, but in some studies, in some patients, it has worked. It has very minimal risk profile. And at this point, you've done 2 transfers, 3 transfers, and we're now at a point where we got to think outside the box and do something different. And that's where intralipid comes in. So yes, so we use it in that context. I wouldn't use it in someone who's doing their first transfer. I wouldn't use it in someone who I really think just needed to have a really good IVF cycle. And have good quality embryos that maybe that didn't happen before. But I certainly would use it in people that have recurring implantation failure, and how that is defined is another story. But I feel like even though it's hard to define, fertility specialists know it when they see it.
Awesome. Yep. We're going to move on, and Dr. Wais touched on it, a little bit. Assisted reproductive technology feels like it changes daily. We see that a lot in our support groups. We hear about all these new tests coming out and all that fun stuff. So we wanted to ask you guys, and I know you're not into research, but is there any new research on the horizon that you're excited to learn more about or that patients should know about?
There's so much out there. I mean, I have to say that the thing that really attracted me in general to the practice of fertility was the fact that it's such a rapidly changing and such a rapidly moving field, right? And then there's always something new and something interesting on the horizon, which like I love. And so, there's lots of areas of interest right now. So, I think a big one will be sort of better genetic testing of embryos. So there, is some rumbling. So right now, when you have an embryo, the embryologist will biopsy. So they'll actually take, 4 to 6 cells from the embryo to send it off for genetic testing. There is some interest now in this non-invasive pre-implantation genetic testing where you're not biopsying the embryo. So there's labs that are working on that right now, and there's some places that are offering that. What I will actually really love to see, though, is genetic testing, but the next level. So, we do PGT, we're looking at the chromosomes, but lots of euploids don't work. There's still something about euploids that we don't know that's preventing them from sticking. So, there's talks about, this whole genome sequencing potentially for embryos and whether that's going to provide more information and to help us predict, like the preliminary studies right now are sort of saying, okay, if embryos have this gene or they don't have this gene, then you can predict whether they're going to work or not, even when they're euploid. It's like, how cool would that be, right?
That's very cool.
Yeah. And then, there's so much interest in endometriosis. So there's a lot of work that, we're participating in at MFC looking at endometriosis, diagnosis of endometriosis mapping ultrasounds. That's a whole other, area.
And I hope that happens for my own sake.
Absolutely.
People who have those questions and are waiting a year for a test to tell them.
Exactly.
Right? So yeah. Amazing.
Exactly. To have some idea, right? And then, there's just more interest in immune. Like, I'm so interested to see what's going to come out of MFC research in terms of immune and the immune treatments. Because, I know what I think and I know how I feel, but to actually see that published research will be incredible.
That's amazing. That's so exciting. I'm so excited to hear about that. And we can't wait to share that with our members as well. And hopefully those things come real soon.
Yeah. Switching gears a little bit, we wanted to talk about the emotional journey for your patients. Another thing that I really appreciate about Markham Fertility is your care for patients and their emotional health along this journey. We know how much that can affect people at Oasis. Do you find that having support and a support network affects patients' treatment? And how do you sort of interact with patients around that kind of support?
Yeah. 1,000%. It's probably the most important question I ask. How are you doing? Really, So it's the difference between surviving infertility or not. I would venture to say it's the difference between having a baby or not, because for 2 reasons. One is people burnt out and they just can't keep doing it without support. And the other time is they keep doing it, but they're like dragging themselves through it and they're not engaged or they detach, because that's a very common tool and I see them usually, the patients that come saying I need immune, I think you need support, like you need somebody to listen, sometimes they come to me so defeated, and I feel like my job is to listen and prep them up and give them hope. And I really believe that I tell them sometimes when I want them to get there for themselves, and Caley can attest to that. And sometimes it's a struggle because they really don't believe me that it's going to work. And when I cannot get them there on their own, I say, okay, here's the deal. I'm going to believe 99% and you're going to believe 1%. But you gotta give me something, when they're so defeated, it's very hard to get good buy-in to your treatment. So I think that, yes, the clinic can do so much in that. And that's something that our MSc has owners, Dr. Wais and I, and Dr. Shan, and all of our doctors, we believe strongly in. The entire team believes in making the patient feel VIP, feel cared for, that they're really the hero of the story. But support, I mean, we can only do so much. We're only with them, at the time of their interaction. They still need to go home and be in the world. So things like Oasis, this is why we're such a big support of Oasis, because there's nothing like having a peer, like your peers, people who get it, give you that kind of support. You don't get it the same from your friends who are fertile marital. You're not going to get it from your mother-in-law, for sure. Oh my God, my mother-in-law is taking care of my kids now. I shouldn't be saying that. No, I think support is so important, and as much as fertility clinics can do better, patients also need to find their own networks outside of fertility clinics, so that they can really survive. Infertility is a disease, it's a journey, and it can be as little as a year, or as long as your entire adult life. So
I just got triggered there so hard. I was like, don't cry out here, because that was like me at the beginning before I found Oasis. I was like, I can't do it. I'm out. Like, and at the time, I guess my doctors didn't. I felt like a number at the time, and when I switched clinics, and it was just that personal connection with my doctor made a huge difference. The support from them, and then again the support from Oasis. And I don't know how many more times I went into our meetings and said, like, yeah, you know what, I'm going into a transfer. Can someone just put the hope on for me, because I'm done. I can't get my hope anymore. So to have people say, like, I'm here and I will hope for you, it really made a difference. So you put it very eloquently into words, my lovely trigger tears here, how we feel. So thank you so much for that, for sure.
Yeah, we talk so much about how hope is painful in this world of infertility. So it's wonderful to have a doctor who can hold a little bit of that hope for us when we can't have it for ourselves.
Yeah, absolutely.
Yep, 100%. So this is our last official question before we get into a couple more questions from our audience who are tuning in. So you both are clearly so passionate about fertility, which we love, and we know it's your job, but we know there's probably difficult days for you too. So what do you find difficult, and what inspires and motivates you to give that amazing care that you both clearly do to your patients?
That's a really good question. That's a really good question. Meivys motivates me. Like you think I'm joking, but when we talk about patients having support networks and like reaching out and everything, like I have my support network, and it's like the other doctors in the clinic who are walk down the number of times that I've walked down the hall to Dr. Garcia's office. I flop in her chair and she gives me the pep talk. And she talks about hope. She has hope for me, who then I can have hope to give to my patients, right? Or the number of times that people come to my office and flop on my sofa. I've got the comfiest sofa in the office, right?
That's right.
So I think that is really important. It's important for the patients, important for us too, to have people in our life who really understand what we're going through, what we're experiencing, and we have the same goals. Because I know that every physician at MFC, we have the same level of passion, commitment, and just this like driving desire to get patients to the place where they want to be. Right. And so, whether it's I'm phoning a friend for emotional support so that I can, because I have a patient who did a transfer and there was a negative beta, and I'm anxious and I'm nervous about the appointment. Right. Or whether it's to ask for help. So, something that's always really important is to be surrounded by people who can provide help to questions, because, we talk a lot about these protocols and medications, and there's not rules or algorithms. I think Dr. Garcia at one point said, it's we just kind of like, we just sort of like make a decision, or we just kind of choose. It sort of feels like, we're sort of, throwing darts and sort of seeing what what sticks to kind of make a protocol decision, because there is no perfect answer. There is no, I think you said one test is going to tell us what the perfect thing is, right? And so a big thing for us is we bring patient cases to rounds every week where we're going to be presenting them to the whole group, embryology, nursing, the other physicians in the group, and we're discussing cases. And we're open, honest, and we have that, we come without egos, right? To say, this is what I decided. This is what happened. What do I do next? What do you guys think? Right?
Wow.
We have lots of those discussions, which I think is really, really important. Apart from that, I do have a life outside of work, as opposed to whatever my mother thinks. But, you know, like it's the people in my life, right? It's my husband, it's my family who keep me grounded, who remind me that, you know, there is life outside of fertility, which you have to, everybody has to remind themselves about that one sometimes.
Yeah.
Life goes on. And it's just being able to spend time with them. And then I know, Dr. Garcia, I don't want to steal your thunder, but like we're both big on like gym goers. Yeah, that is another big thing. So like I will go and I will run my little heart out on my treadmill when I'm very anxious, or lift really heavy things to make myself feel better. And you know, it's about, I really want to show up as my best self for my patients every day. And that's really, really important to me. It's not just about the medicine. Right?
That's amazing.
It's about, I have to take care of myself so that I can be my best self for those appointments. So I can give it that 120%, right? All the time. And, you know, setting those boundaries and knowing when, you know, you need some time off too.
That's amazing. It shows. It definitely shows. Dr. Garcia, do you have an answer for that one too? Because we would love to know.
Yeah, I mean, I realized I'm an empath by nature, and I realized very early in my career, she's nodding. I'm a big empath, and I realized very early in my career that I was not going to have any longevity in this career if I didn't figure it out, like how to be an empath and how to also cope, because all day, every day, I was like getting, I was seeing patients in pain and suffering and wanting something so badly, and I was feeling so much for them. So I had to think, okay, I don't want to turn into like a person who doesn't care, because that's not genuine to who I am. And if I turn into that, I don't want to be a doctor anymore. And at the same time, I need to create space for my patients without jumping in the pool with them. Because if I jump in the pool with them, they go down, I go down, and nobody has a baby. Right? So I earlier in my career, I had that like light bulb moment where I was like, you know, what am I going to do? How am I going to do that? And I study. I have a spiritual practice. I write. I actually became a life coach, not because I wanted to be a life coach, but I didn't become a life coach. I did the training. I got the certification to be a life coach. I never practiced, but I wanted to learn.
I think you inherently practice on me and Dr. Stan.
Right. So
on the couch.
So I wanted to have that skill of being able to, hold space for patients. That's what life coaches, like, hold space so that they can find their own place in wherever they are. So I've done that, and I exercise. I go to bed really early. Everybody knows you cannot get me after 9 p.m. I'm just not awake. I don't exist. So I take really good care of my mental health from that point of view. I eat healthy, I exercise, and I spend quality time with the people that I love, because yes, you have to put your oxygen mask on first. It sounds like a cliche, but that could not be. That is one cliche that is so true. Is I know when I'm feeling run down, when I'm feeling burnt out, I just cannot show up as my best self. And that's when it's the time to go on vacation or take a break or take a morning off or do something completely different. And
did you find that especially hard when you, like, because you've been through the journey yourself, or do you find it easier for the empathy because of it?
I think now that I'm past that, like I have my children, I love that I had that experience, because I don't think I feel more, but when I tell patients I get it, they really get it, right? Like there is something in their eyes lift up and they're like, oh, okay. So it's one thing to say, it's a miscarriage and you're going to take this medication and you're going to feel this and that, to be like, I've experienced that. And in one miscarriage, I had pain. In another one, I didn't. There were, I was about this gestation age, which is the same that you are. So that really matters for them. And while I'm not happy that I had that experience, I'm happy that I can now use it to give them that peace and that sense of connection. One, I was going through it. It was really hard because I had a lot of shame. I was not open about my journey. I became very open after the fact, but I wasn't while I was going through it. Part of it is I just couldn't open that door because I was going to fall apart, right? So I had to keep that, the door closed all the time so I could function. And the other part of it is that I was embarrassed. I was like, I'm like the fertility doctor who can figure herself out, can figure her infertility out, which I now realize is silly, but that was really what was going through my mind at that time. And I felt like if my patients knew that I had done IVF and failed, and done IVF and failed, and had a miscarriage and another one and a transfer and another transfer, they wouldn't trust me because then I clearly don't know what I'm doing because I can't even help myself. I know it sounds so silly, but that was what was going through my mind. So that was really difficult. And I was delivering babies at the time because that's part of my past life. I was doing IVF and delivering babies, and that was.
That just makes you a warrior.
True
warrior. Holy smokes. True warrior.
Some people just didn't want to have these babies and made it clear sometimes. And I mean, it's about choice and patient autonomy, and everybody gets to decide. But it's just hard when you're going through something hard. And there is somebody else that has what you want and maybe doesn't appreciate it the way that you would have appreciated if you had it. But so I think what I learned from that is just put your own oxygen mask first and take care of yourself so you can take care of other people.
Well, again, I think that passion shows through both of you so much. And so thank you for answering all of our very tough questions. Some of them I see, and sorry about that. But also thank you for supporting Oasis as much as you do. We do have a couple questions. Caley, do you want to hit up those?
So one of the questions someone asked is, how important is lining thickness, and what is a good lining thickness for a transfer?
Great question. So lining thickness refers to the lining of the uterus. We know that as it grows, generally grows under the influence of estrogen. And so we want to get to a nice looking lining, a good lining thickness to do an embryo transfer so that, better pregnancy rates. So there was this really big study that was published actually by a bunch of Canadian REI physicians. I think the head author was Kim Liu, who's one of the REIs at Mount Sinai. I don't remember who the other authors were, but they looked at a bunch of Canadian data and they looked at lining thickness and pregnancy rates. And so out of that study really came out that for a fresh embryo transfer, lining thickness at around 7 millimeters, and frozen embryo transfer, again, around 7 millimeters or greater, you're going to hit maximal pregnancy rates. Of course, assuming that the inside of the cavity, like inside of the uterus, looks good. There's no polyps or anything like that. But again, it doesn't mean that no one gets pregnant if the lining is like 5 millimeters, right? Yeah. It's all about sort of what is optimal and what is like the top, what's going to give the best pregnancy rates, right? On the flip side, having a thicker lining, so if you're like 9 or 10, doesn't mean you're extra fertile.
Oh, okay.
Like once you're kind of like at that point, like beyond that, it's just gravy. Like it doesn't really necessarily increase the pregnancy rate. So it's important, but again, it's not, I mean, I've had lots of patients who had pregnancies with linings at 5 millimeters, 6 millimeters, because that's probably just what their body does.
Okay. And this is a follow-up that is super specific. So she says, would you say a lining that doesn't thicken past 7 or 7.5 millimeters is an issue with blood flow and can lead to implantation failure and recurrent pregnancy loss?
So yeah, so super specific question. So, I mean, I wouldn't say that off the bat, right? So a lining that doesn't thicken past 7 7.5 millimeters, that doesn't necessarily mean that for sure the cause of implantation failure is the lining.
Right.
You know, as we talked about, there can be so many other things that can be going on. And sometimes there can be more than one thing going on, right? You know, I always tell people, like, listen, we do these studies on patients who are doing IVF, who are doing embryo transfers. We don't really actually know what kind of I'll use Dr. Garcia's phrase, the fertile myrtles, what their uterus linings are. You know, like, it's very possible that there is a spectrum. I mean, there's short people, there's tall people. Maybe some people have thinner linings. Maybe some people have thicker linings, just kind of a baseline. And they're still conceiving. So, you know, maybe that is your normal. It doesn't necessarily mean that that is for sure the issue. There can be so many other things going on.
Mm-hmm.
Excellent. Thank you so much. So we are coming right to the end here. So we just want to say, if there's any more questions, get them in right this second, because we're about to log off. You can check out Dr. Wais and Dr. Garcia on their Instagram and their podcast, MyFertilityPodcast. They have lots of great information on there. You can check out Oasis's podcast wherever you stream your favorite podcasts. All of our new Fertility Village Live will also be on there, so you can rewatch this episode if you need to check back for any of those answers. And then, Caley, am I missing anything? Oh, check out, of course, check out Oasis FSN if you need support. Join our monthly support groups. We do virtual and in person, hopefully in a city near you. So please reach out anytime. And thank you again to our lovely doctors for joining us. We appreciate you so much for answering all of our questions and those of the people watching. We haven't come any in, so you're off the hook. But thank you again. We always appreciate your support. And I'm sure Caley will see you again soon.
Maybe. No, thank you so much. And thank you so much for your support of Oasis.
Great.
You've
Thank
both
you.
been amazing. Yes.
Thank you for having us. Oasis is a wonderful organization. So, yeah.
Absolutely.
Thank you.
For the amazing work that you guys do. And yeah, thanks so much for having us.
For sure. Anytime.
Guys, thank you. And bye. Yay.